Now, here we'll talk about lung compliance and a couple of clinical applications when it comes to the pulmonary system. So, lung compliance is defined as the magnitude of change in the lung volume produced by a given change in the transpulmonary pressure. So, what does that mean in simple English? It means that a compliant lung, when you try to expand the lung, it will actually expand with you as you inhale air. So the greater the lung compliance, the easier it is to fill up the lungs with air. And there are two major things that determine lung compliance. Number one is the stretchability and of the lung tissue, and so the health of the alveoli. And number two is the presence of surfactant in order to overcome the surface tension found in the alveoli. And we kind of touched on surfactant a little bit, but we want to learn a little bit more about it. So we do know that it's secreted by the type 2 alveolar cells. It is a mixture of phospholipid and protein. It acts kind of like a detergent that decreases the surface tension of the alveoli. Again, the surface tension of the alveoli tends to cause alveolar collapse. Surfactant prevents the alveoli from collapsing because it overcomes the surface tension, which means that we need surfactant in order to increase our lung compliance. We are continuously making surfactant all the time. Just because we inhale air, that stretches the type 2 cells, and that stimulates these cells to keep on producing surfactant. In utero, we are not producing, so a fetal lung isn't producing any surfactant because there's no stretch of the cells. These cells don't start producing surfactant in preparation for that first breath until late in gestation, late in the pregnancy, and it is stimulated by the high levels of cortisol that occurs towards the beginning of delivery. So a clinical application to this physiology would be a condition known as the respiratory distress syndrome of the newborn. And this tends to happen in premature infants where their lungs are not ready, they're not making enough surfactant, which means their lungs aren't compliant enough and it's very hard for them to breathe. They have what is known as labored breathing, or which is a very exhausting process for these little tiny creatures. It could lead to respiratory failure and eventually could be fatal. It's treated with a mechanical ventilator and the administration of either natural surfactant or synthetic surfactant through an endotracheal tube. Now, airway resistance is the passage of air through the trachea and the bronchi and so on. And remember, we talked about how these are low resistance passages. But there are things that might increase the resistance to the flow of air, and especially if we change the radius of these, basically of those tubes. So number one would be asthma. Asthma is a disease where there are these intermittent episodes of the constriction or the decrease in the radii of the air pathways. And when you decrease the radius, there is an increase in the resistance to the airflow, and it makes it harder for these patients to breathe. There are actually three different things going on in asthma. The number one and the most important is the chronic inflammation of the airways. So that chronic inflammation leads to the swelling of the airways, and that occurs especially in chronic allergies or if there is a viral infection. Sometimes just the exposure to these different allergens like cold weather or exercise or a viral infection or tobacco smoking leads to that chronic inflammation and swelling of the airways. The other two are kind of related to that. So the other two are the increase in the production of mucus and the constriction of the smooth muscles of the airways. All three of these together are going to decrease the radii of the airways, making it harder again for the patients to inhale and exhale. Now, in order to treat asthma, your number one aim would be an anti-inflammatory drug to decrease that inflammation, to reduce that chronic inflammation that is happening either due to the constant allergies or if it is kind of provoked by a viral infection or whatever is causing that hyperresponsiveness. So there are different ways to treat asthma. Again, the first line of treatment would be to give a leukotriene inhibitor, which leukotrienes are important in the inflammatory process. So you're going to give something to inhibit these leukotrienes, which are chemicals that the immune system uses to communicate together and enhances inflammation. So give the inhibitors to these leukotrienes. For example, the most common one is montelukast or Singulair, or the patients can get inhaled glucocorticoids, and again, the most common one is Pulmicort. Now, the second way, or the second aim, is to overcome the over-responsiveness of the smooth muscles and preventing them from contracting. So give them a bronchodilator to relax the airways. For example, albuterol, which is a beta-2 agonist. So remember when we talked about the adrenergic receptors, we said there are alpha and beta. One of them was a beta-2 adrenergic receptor. These are the receptors that are found in the smooth muscle fibers of the airway. So these patients, when they get, for example, albuterol, which activates these beta-2 adrenergic receptors, that leads to the relaxation of the smooth muscles. Another, but is definitely less common kind of medication would be a medication that blocks the muscarinic cholinergic receptors. Remember, cholinergic receptors were parasympathetic receptors that respond to acetylcholine. So you want to block them. And again, for example, atropine, but this is definitely not a common use in bronchial asthma. So the most common ones would be leukotriene inhibitors and inhaled glucocorticoids, bronchodilators, especially during an attack, and in particular, we use the beta-2 adrenergic receptors. Now, COPD, that stands for chronic obstructive pulmonary disease, and this refers to the presence of emphysema or chronic bronchitis, but more commonly it's a combination of both. So what is emphysema? Emphysema is the destruction and the collapse of the smaller airways. And this usually happens as a very gradual process. It could be due to long-lasting bronchial asthma or chronic, smoking for a very long period of time can lead to the destruction and collapse of these small airways, and again, that is known as emphysema. Chronic bronchitis is that chronic inflammation of the bronchial walls that again could be due to smoking, leading to the excess mucus production, and again, the chronic inflammation means that there's chronic swelling in the airways. Again, most patients have, a combination of the chronic bronchitis and emphysema together. Now, this ends this portion. In the next portion, we'll talk about the spirometry and the lung volumes.